Good morning, and thank you for allowing me to present our research. Recurrence after prolapse surgery, does partial avulsion of levator and eye muscles matter? These are our disclosures. Pelvic organ prolapse is a common condition. Estimated 200,000 surgeries for prolapse are performed in the United States alone. And recurrence after prolapse surgery is a significant clinical issue. In the past, the following predictors of recurrence have been identified: younger age, family history of prolapse, poor pelvic floor muscle contractility, BMI, lower genital hiatus, and most recently, complete avulsion of levator and eye muscles. Therefore, our objectives were to determine whether partial avulsion of levator and eye muscles is a recurrence factor for prolapse recurrence is a risk factor for prolapse recurrence after surgery. We used combined data from 6 separate clinical projects, a prospective clinical trial, and 5 clinical audits looking at prolapse recurrence after surgery. They all took place at tertiary urogynecologic units in Australia. All subjects underwent standardized clinical interview, PAP-Q examination, and 4D translabial pelvic floor ultrasound. We used 4 definitions of prolapse recurrence. Subjective recurrence was defined as patients reported symptoms of vaginal lump or a dragging sensation. Objective recurrence was defined as a PAP-Q stage 2 or more in any compartment, prolapse to the hymen or below, and a cystocele on ultrasound of 10 millimeters or more below the pubic symphysis. We used tomographic ultrasound imaging to visualize levator and eye muscles, and this is an example of a TUI. There are 8 images obtained during the process in axial planes, and there are 2.5 millimeters at 2.5 millimeter intervals. Slice 0 is a reference slice, and it's at the point of minimal dimension. Positive slices are cranial, and negative slices are caudal from the reference slice. And a definition of a complete avulsion is an abnormal attachment of a levator and eye muscle to the pubic ramus in all 3 central slices, slices 0, 2.5, and 5. A partial avulsion is defined as an abnormal attachment of the levator and eye muscle in at least one of the central slices, but not meeting definition of a full avulsion. And this you can see on the patients right here. We used 4D view software to analyze ultrasound images. Investigators analyzing ultrasounds were blinded to all clinical data, and we tested the following predictors of prolapse recurrence: age, BMI, time to follow-up, previous hysterectomy or previous prolapse surgery, history of vaginal delivery, forceps, age at the first delivery, anterior compartment mesh, hiatal area, and presence of complete or partial avulsion. And we used univariate statistics and logistic regression modeling. And these are our results. During the study period, there were 792 women who underwent prolapse surgery. 545 women were present for follow-up and agreed to participate in the study. The average time to follow-up was 2.3 years. The mean age was 63. 42% of women had previous hysterectomy, and 26.6% had previous prolapse repair. Study participants underwent a variety of procedures, and they're all listed here. Hysterectomy, 32% of women underwent hysterectomy. 34% had a vault suspension. Half of those were sacrocolpopexies, and half were sacrospinous ligament fixations. 51.7% had anterior mesh placed, and 14.7% had a posterior mesh placed. Postoperatively, 26.6% of women reported symptoms of prolapse. 71.7% of women met objective recurrence criteria based on PAP-Q stage of 2+ or more. Complete levator avulsion was noted in almost half of all the women, and partial avulsion was much less common, present in 16.6% of women. Partial avulsion, highlighted here, was not associated with an increased risk of prolapse recurrence by any definitions. Hiatal area was found to be a risk factor for prolapse recurrence by all definitions, and anterior mesh decreased risk of prolapse recurrence. In conclusion, partial avulsion of levator ani muscle was not associated with the increased risk of prolapse recurrence after vaginal surgery. Thank you, and I welcome your questions.
Questions from the floor? Yes, Gil.
Thank you. It's good to present a negative result. I thought it was a powerful statement. When you're looking at your partial tears, you said only one slice showed the... Could you break it into which slice might be more important?
Which slice?
Where your tear is, basically, on the pubic rami, does that seem important? Sorry, I'll say it in English. The type of tear you had on ultrasound, you had only one of 3 slices only needed to be affected. Could you make any comment about any type of slice? Which position of the structure of the tear was it?
So I think I hear a question. We call them the reference slice is the point of minimal dimension. It's at the level where pubic symphysis come together. And the 3 central slices are 2.5 millimeters above that, and another one is above that. So it's cranial to the reference slice. I'm not sure if that answers the question, but maybe we can talk after.
Maybe I'll try to help out. It doesn't really matter which level. As far as it doesn't fulfill the criteria of full avulsion, it doesn't seem to matter which slide is more important. As far as Anna's data show, actually, partial avulsion doesn't matter, and which level actually doesn't matter either. Also.
Thank you. Yep.
Could I pose a question as well? Pia Tillman from Sweden. Thank you for a nice study. Your group of prolapse patients was extremely mixed, and the kinds of surgeries were extremely mixed with native tissue repair, sacrospinous fixation, mesh. Did you look at the group of native tissue repair specifically, and could you see any difference there? Because I think it's rather difficult to compare the mesh group to the native tissue repair group.
We did not do any sub-analysis as of yet. That data is available, and we could look at it. I agree that they're extremely mixed patients population, and most of the time the meshes were used in people with more advanced prolapses, which probably were likely related to complete avulsions. But that's definitely something that we can look into, and we have not done that yet. Because
the mesh itself could compensate for the levator avulsion, perhaps.
Right. We've shown that mesh decreases the risk of recurrence. That's correct.
Any other questions? Thank you very much.